So today we will do the dissection part of the orbit. So in the dissection of the orbit, we go in the anterior cranial fossa and we break the roof of the orbit, which is formed by the horizontal orbital plate of the frontal bone. As this is the diploid, the frontal bone, this is the foramen cecum, this is the crista galli, and on the other side is the cribriform plate of the ethmoid bone, and it is bounded by the lesser wing of sphenoid with anterior clinoid process. And here lies the optic canal, and this is the sulcus chiasmaticus, this is the pituitary fossa, and this is here lies the foramen lacerum. So this is the orbital plate of the frontal bone. It forms the roof, and there is the alphabet S-shaped elevation is there, and this S-shaped elevation forms the S-shaped orbital sulcus on the inferior surface of the frontal lobe of the cerebrum. So in the dissection, when we go on to the dissection of the orbit, we break the roof of the orbit. So as we remove the or dissect the remove the roof of the orbit, immediately in the first encounter after breaking the roof of the orbit, what we see here, a very important relation L, F and T. Just we have removed the periosteum and periorbital fat. Below the periorbital fat, when we remove in the roof of the orbit, we see three nerves and three muscles. Just by removing the nibbling the small pieces of the orbital plate, we find three nerves from lateral to medial. Lateralmost is the lacrimal nerve, this is the frontal nerve, and T stands for trochlear nerve. So three nerves we encounter. How to remember? Liver function test. L for lacrimal nerve. So lacrimal nerve naturally it supplies the lacrimal gland, which is situated superiorlaterally. F stands for frontal nerve. Frontal nerve will also be branch of the ophthalmic division of the maxillary. Trigeminal nerve. Lacrimal nerve is the branch of the ophthalmic division. T stands for trochlear nerve. So trochlear nerve has got three specialties. Number one, it is the thinnest cranial nerve. Number two, it has crossed fibers. Third, it is the only nerve out of the 12 cranial nerves which arises from dorsal surface of the brain. So these are about the trochlear nerve. So LFT, see Sangal G, and below these three muscles, just below the trochlear nerve medial bone, we see below this the superior oblique muscle passes. Just below the frontal nerve, another muscle we encounter here. This is the LPS, levator palpebrae superiosus. Only there is a muscle for the upper eyelid. Lower eyelid is stationary. And in relation to the lacrimal nerve, laterally, here lies a muscle that is the lateral rectus. So this is the third muscle we encounter, that is the lateral rectus. So three muscles, three nerves. And frontal nerve is seen anteriorly dividing into a medial supratrochlear and a lateral supraorbital nerve. So medial is supratrochlear nerve and lateral one is the supraorbital nerve. Both are the branches of the frontal nerve we see in the first line of the dissection. After seeing them, the next step. In the next step, we see the outline of the posterior part of the eyeball, and from its posterior part a tortuous optic nerve is present, which is coming out through the optic canal here, and both the optic nerves, they cross anterior to the pituitary fossa, touching the sulcus chiasmaticus here, and this is the optic chiasma. So this is seen in the anterior cranial fossa as the two optic nerve coming and they are crossing against the sulcus chiasmaticus, and then they again go forming the optic tract. And what we see here, that the superior oblique, which is the medialmost muscle here, it is going medially and it is passing through a pulley-like fibrous, they call the trochlea. And from here, this superior oblique muscle turns backward and laterally, and it is inserted over the upper outer posterior quadrant of the eyeball, because it has to bring about the intorsion movements. So we see the course of the superior oblique muscle and passing and inserting over the posterior upper part of the lateral part of the quadrant of the eye. Below the LPS, parallel to here, we another see a muscle going below and parallel with the optic to the LPS, and this muscle is the superior rectus. This is the superior rectus. So in the next step of the dissection, we see the superior rectus just below the LPS, and when we see the superior oblique muscle just below and parallel to it, we see here the medial rectus muscle. Medial rectus, this is superior rectus. And what else we see? That the abducent nerve is entering the ocular surface of the lateral rectus muscle. So this is the second step of the dissection we see here. Again we see three muscles: nerve supply of lateral rectus, superior rectus, and medial rectus. The medial rectus is also seen, a nerve is entering on its ocular surface. This is the oculomotor nerve, while the oculomotor nerve supplying superior rectus lies on its inferior surface. For that we have to reflect it laterally or medially, and we see the entry of the oculomotor nerve in the ocular surface of this muscle, that is superior rectus. After this, we cut the superior rectus muscle and we reflect it superiorly or inferiorly to expose the, number one, we will see the insertion of the superior oblique muscle, plus we see the tortuous course of the optic nerve. Optic nerve is tortuous because eye is a movable structure. So because of the movement of the eye, to accommodate the movement, the optic nerve in the orbit is tortuous. So we see the full length of the optic nerve after removing the superior rectus muscle. What else we see here? That ophthalmic artery. So ophthalmic artery comes from the inferior-lateral part of the optic nerve. It is a branch of the internal carotid artery which lies in the foramen lacerum. And this internal carotid artery which lies in the foramen lacerum is surrounded by the sympathetic plexus around it. And here it forms the sinuous course, the carotid siphon on the lateral surface of the body of the sphenoid bone. So this is the body of the sphenoid bone, this is the lateral surface of the body. Here forms the carotid siphon. After forming the carotid siphon, this artery again becomes straight and goes upward, and it is continued in the lateral circus of the cerebrum as the middle cerebral artery. While here, the internal carotid artery gives its terminal branches. One is the middle cerebral artery, another is the ophthalmic artery which runs inferior-lateral to the optic nerve. And inferior-lateral it reaches into the orbit and it gives various branches to the muscles of the eyeball. So this is the course of the inferior-lateral to the optic nerve is the entry of the ophthalmic artery branch of this field. So these things we see here. Another important thing we see near the apex of the orbit here, between the optic nerve and the lateral rectus muscle. Here lies a very minute ganglion hanging from a branch of the oculomotor nerve, which is going to supply the inferior oblique muscle. So this is the ciliary ganglion. So anatomical position is it lies near the apex, medial to the optic nerve, lateral to the optic nerve, and medial to the lateral rectus. So here, and it is very small size, 1 to 2 mm size, or what is called the pinhead size. So this small ganglion is situated here near the apex of the orbit. So this is the base of the orbit. This is the medial wall which is almost straight, while the lateral wall of the orbit is oblique. So this is what is the boundary of the what is called the orbit, and this optic canal it lies just medial to the apex of the orbit. So here we see the optic nerve. In the third step of the dissection, we reflect the optic nerve laterally or medially and below this optic nerve and parallel to it, what we see here is the muscle that is called the inferior rectus. So inferior rectus muscle is visible below and parallel to the optic nerve. And also we see a branch of the oculomotor nerve is entering on its ocular surface. The nerve supply of the inferior rectus, the oculomotor nerve. So this is how we do step by step the dissection in 3 steps, and we see all the extraocular muscles, the ophthalmic artery, and the ciliary ganglion also, and trochlear nerve and apicocylindrome, all the 3 nerves supplying the muscles we see. We also can see the veins below the inferior rectus, and all these veins posteriorly, they form the superior and the inferior ophthalmic veins. And these superior and the inferior ophthalmic veins leaves the orbit through the superior orbital fissure in its lateral part, and the inferior ophthalmic vein, it leaves the orbit through the inferior orbital fissure, and both of them, they open into the cavernous sinus, which lies over the foramen lacerum and internal carotid artery. So superior ophthalmic and the inferior ophthalmic veins both are the tributaries, anterior tributaries of the cavernous sinus. So this is how we do the dissection of the. Now comes the ciliary ganglion. So ciliary ganglion, like we have done the otic ganglion, the sphenopalatine ganglion, submandibular ganglion, they are the all peripheral parasympathetic ganglion. And they form the cranial part of the parasympathetic nervous system. The anatomical position, we have already seen that it lies just near the apex of the orbit, between the optic nerve medially and laterally, and it is hanging from a branch of the oculomotor nerve which is supplying the inferior oblique muscle. That is the anatomical position. Regarding its size, it is 1 to 2 mm in size. So it is like the pinhead size, very small, but very important ganglion, like the otic and all other ganglions we have done. So this ganglion has got the 3 roots. One is the parasympathetic root, other is the sympathetic root, and third is the sensory root. And as we have seen that the oculomotor nerve enters the orbit and divided into 2 branches, that is the superior divisions and the inferior division. The third, that is the oculomotor nerve. The superior division supplies superior rectus and LPS. The inferior division is supplies the medial rectus and the inferior oblique muscle. So the branch of the ocular nerve which supplies the inferior oblique muscle, to this a ganglion is hanging, that is called the ciliary ganglion, very small ganglion. So the parasympathetic root. So parasympathetic root, it comes from the midbrain and with the Edinger-Westphal nucleus. So Edinger-Westphal nucleus is a parasympathetic nucleus, and it is situated at the level of the superior colliculus of the midbrain, very near to the oculomotor nerve. So this is the Edinger-Westphal nucleus and situated near the third nerve nucleus, from where the third nerve is coming to reach the orbit to supply it. So the same third nerve, the oculomotor nerve nucleus in the midbrain, it accompanied by the preganglionic parasympathetic fibers coming from the addengal Westphal nucleus. It is also present in the para-aqueductal gray matter of the midbrain. So these preganglionic parasympathetic fibers, they reach the orbit through the oculomotor nerve, and these preganglion fibers, they go into the ciliary ganglion and they relay here. After the relay, the postganglionic fibers, they come out as the short ciliary nerves. They are called short ciliary nerves. So these short ciliary nerves, they contain postganglionic parasympathetic fibers made to supply the smooth muscles in the eyeball. And these short ciliary nerves, they pierces the sclera of the eyeball So as we have done this, the sclera of the eyeball, the anterior part is the transparent part is the cornea, and the second layer which is the choroid with the iris, the ciliary body with the ciliary muscles, to which the suspensory ligament, the biconvex lens is attached, is hanging. So these short ciliary nerves, they pierce the sclera and then they enter into the choroid, and from the choroid these postganglionic parasympathetic fibers, they supply the ciliary muscles in the ciliary ganglion in the body. Thus these postganglion fibers, they also go into the iris, and in the iris they supply the circular smooth muscles of the iris, which is called sphincter pupillae. So this is how parasympathetic fibers, they from the midbrain, they reach the destination, that is the muscles. So with this muscle there is a constriction of the pupil, and when the ciliary muscles they are contracted, this lens, ciliary muscle contracts and this lens is stretched and its diameter decreases, and this is responsible for the accommodation reflex. So whenever we are seeing the distant vision, suddenly we want to see a near vision, so our lens accommodates us to see a distant vision and immediately switch on to the near vision. It is because of the change in the thickness of the lens of the eye. And who is doing this, changing the thickness during distant and the near vision? Ciliary muscles present in the ciliary body, supplied by the parasympathetic fibers. So this is how we explain the first root, that is the parasympathetic root of the ciliary ganglion. Now second is the sympathetic root. As we know, the ophthalmic artery is entering into the orbit inferolateral to the optic nerve. So this is the branch of internal carotid which is surrounded by the sympathetic plexus. Same sympathetic fibers, they surround the ophthalmic artery, and this ophthalmic artery with the sympathetic plexus around it reaches the inside the orbit. So these sympathetic fibers, they are already post-ganglionic. So these sympathetic fibers from the ophthalmic artery, they enter into this ciliary ganglion, and they also reach to the short ciliary nerve, pierces the sclera and reaches the choroid. And from the choroid, these sympathetic fibers, they reach the iris and they supply the radial muscles of the iris. And this radial muscle, we know, is responsible for dilatation of the pupil. So this is how the smooth muscle they got their sympathetic as well as the parasympathetic nerve supply through the ciliary ganglion. Third root of the ciliary ganglion is sensory. Usually the sensory nerve, so cornea is a sensory part of the eyeball. So it is sensitive to the pain, temperature, pressure and touch, that is the general sensations. So nerves starting from the cornea, carrying these general sensations, they run in the cornea and they come out of the cornea, out of the core of the sclera, as the long ciliary nerves. And these long ciliary nerves, they leave the orbit by passing to the superior orbital fissure inside the annulus of the Zen. Then these long ciliary nerves, they go into the ophthalmic division of the trigeminal nerve, which is already having a, we have seen the frontal branch, which gives the supraorbital and supratrochlear nerve. It also gives the lacrimal branch in the orbit. Third is the long ciliary nerve. So this is the usual pathway of the general sensations through the long ciliary nerve to the ophthalmic division, ophthalmic to the trigeminal, and trigeminal it reaches the brain, that is the pons. But sometime in the alternative pathway, these nerves from the cornea carrying the general sensations, they traverse the choroid, the sclera, and through the short ciliary nerves. These sensory nerves, they pass through the ganglion, and after that they reach the ophthalmic division of the trigeminal. So this is the alternative pathway. The sensory sensations from the cornea reaches the ophthalmic division. So that's why ciliary ganglion is also said to be having the sensory root also, but sometime. So this is all about the small ganglion, that is ciliary. Regarding its applied anatomy, applied anatomy of the extraocular muscles, that is also done. So whenever there is an injury of the third nerve, and third nerve bringing the movement of the adduction movement, the medial rectus is supplied by the third nerve. If third nerve is injured, but the sixth nerve is okay, then the eyeball will be rotated, will be in the abduction position. So this is called the divergent squint. And because one eyeball is on the rotated right side, on the vertical axis, because of the unopposed action of the lateral rectus, patient will have got the double vision or diplopia also, with the divergent squint. Opposite is the abducent nerve injury. In the abducent nerve injury, lateral rectus is not active, it is paralyzed. Medial rectus is okay, oculomotor nerve is okay. Then the eyeball is rotated medially. And then this is called the divergent type of the squint, and here we see the divergent, the convergent type of the squint. This is the convergent squint in the lateral rectus or sixth nerve injury. So patient will come, and when you examine the eye will be, eyeball is rotated in the vertical axis medially, so it is called the convergent squint. Again, patient having the diplopia also. So these are the encountering the squint due to the lateral rectus and the medial rectus injuries there. Another injury of the oculomotor nerve can cause the drooping of the eyelid, that is called the ptosis. The ptosis is due to the injury of the third nerve and the paralysis of the LPS, levator palpebrae superior. Usually our upper eyelid, it covers 1/10 of the circumference of the cornea. 1/10. But because of the paralysis of the LPS, there is a drooping of the eyelid, and the eyelid can come down now. And a small part of the cornea is visible. So this condition is called the ptosis. This is due to the injury or the LPS ptosis. Then damage to the ciliary ganglion lead to the problems to the patient. So injury to the small ganglion, that is the ciliary ganglion, what problem a person can have? So first is there will be loss of the maybe corneal reflex. In the corneal reflex, if a patient come in the coma, in an unconscious patient, and we without CT scan, in the first examination we want to see the injury of the brain, whether it is there or not. Then in the dark room, we open the eye of the patient and we touch the cornea of the unconscious comatose patient with the glass wool. As we touch the cornea, is so sensitive because the sensory route is going through the ciliary ganglion to the ophthalmic division to the brain. There will be blinking of the eye. When by touching the cornea, if this blinking is there, it means corneal reflex is okay. The ophthalmic division of the trigeminal nerve is okay. Trigeminal nerve is okay. Pons is okay. Or in other words, the brain is working. So that is the indirect test we do. Ciliary ganglion is helping. Second is the light reflex. But in the ciliary ganglion injury, the corneal reflex will be lost. Then comes the light reflex. Same patient in the dark room, now we put the light by opening the eyelids of the unconscious patient, we put the light on the iris. And we see the erection of the pupil. If the pupil is dilating, it means radial muscles of the iris, they are working. And if there is a constriction of the pupil, by putting the light, it means sphincter pupillae or circular muscles, they are contracting, they are working. as these muscles they are supplied by the parasympathetic fibers coming from adrenal westport nucleus through the short ciliary nerves, through the ciliary ganglion. It means ciliary ganglion is okay, and this light reflex is okay, the adrenal westport nucleus is okay, midbrain is okay, and brain is okay. So this is the indirect test. Without CT scan, we can tell the relative of the patient that his or her brain is working. But if only light reflex is absent, if you are putting the light on the eye and there is no reaction of the pupil, it means light reflex is gone, sympathetic fibers are gone, ciliary ganglion is lost. So damage to the ciliary ganglion will cause the loss of the light reflex. No pupillary changes. Third is the accommodation reflex is also lost in the ciliary ganglion injury. So three problems will be there after the ciliary ganglion. All these three reflexes will be lost in the small important ciliary ganglion is damaged. So the accommodation reflex, we ask the patient to see a distant vision and suddenly what we see that we say that what is written over here, he will be unable to tell. He says that I can see a distant vision, but at the same time I cannot see the near vision. It means his accommodation reflex is gone. Means his ciliary muscles has been gone in the ciliary body because no change of the lens is done, and these ciliary muscles are supplied by the ciliary ganglion, short ciliary nerve. It means ciliary ganglion is damaged, or oculomotor nerve is damaged, who is carrying the parasympathetic and the parasympathetic fibers to the ganglion. So this is the indirect test. The accommodation reflex, corneal and the right reflex will tell the whether ciliary ganglion or accompanying third nerve or ophthalmic division of the trigeminal nerve is working or not. So this is the applied anatomy related to the ciliary ganglion. Thank you.